Welcome, everyone. It's wonderful to have so many of you in the room and to see so many faces online as well. I want to offer a special welcome to today's Dean Lecture featuring Dr. Aletta, Nonyane, and her family here in the front row, who I'm so excited to welcome. And I also want to welcome her friends and loved ones joining us virtually, including many from South Africa. So again, welcome all of you. I'm Keisha Pollock Porter. I have the great privilege and honor of being Dean of the Bloomberg School of Public Health, a role that I've had for just about 6 weeks. It's been a whirlwind and a joy, and I'm excited to preside over my first Dean's Lecture. This series was established under Dean Al Sommer to highlight the extraordinary work of our newly appointed and promoted professors and senior scientists. Attaining a faculty appointment at this rank confirms not only the respect and high regard of the school, but also of colleagues across the nation and throughout the world. These lectures are an opportunity to celebrate our colleagues, to hear firsthand how they are changing the world through their role in public health. Today, again, I'm so pleased to introduce our speaker, Dr. Aletta Nonyane. Aletta is a biostatistician, a research professor in the Department of International Health, and a key contributor to some of our school's most important TB and HIV projects. Aletta earned her bachelor's and master's degrees from the University of KwaZulu-Natal in South Africa and a PhD from the University of Edinburgh. She was working as a research fellow in the London School of Hygiene and Tropical Medicine when she was recruited to the Bloomberg School of Public Health by two pillars of our International Health Department, Bob Black and Larry Moulton. They happened to be looking for a statistician, and of course, Aletta was there. And she provided much needed support for the department's work in HIV, vaccine access, child health, and more. They were impressed with Aletta's experience and her passion for the work. And in the 15 years since, Aletta has emerged as a leader at the Bloomberg School. Today, she is our go-to biostatistician for TB and HIV research and cluster randomized trials, work that links our school to the global health community. She has made significant contributions to the rigorous statistical work needed to reduce the burdens of HIV, TB, and other diseases around the world. Through statistical design and analysis methods, she is helping us to understand which interventions improve access to healthcare services. She is making an impact from India to Ethiopia to Peru and many more places besides, as she evaluates everything from new diagnostic tests to national health systems. Aletta's work has also led directly to policy change. As just one example, thanks to her research, South Africa has adopted targeted universal TB testing. Saving lives, millions at a time, is a team effort. And throughout her career, Aletta embodies this. She is also strongly committed to teaching and mentoring, whether it's the Bloomberg School students or international trainees. She is particularly passionate about research capacity building in Africa, where she has given short courses and also directs a postdoc program for the Center for AIDS Research. Aletta's colleagues will tell you that she is always ready to support and help those around her, giving so much to the school and to the field, while also modeling work-life balance. Maybe we can ask her family about that. She is incredibly devoted to her two children and to looking after her family in South Africa. And again, I'm so thrilled that her family is here with her today. Before I hand things over to Aletta, I'd like to offer a few final words from Aletta's colleague, a longtime faculty member, Andy Ruff. Andy shared the following words: Aletta leads by example. She is unafraid to try new things. She always helps us to be respectful and inclusive of our colleagues, and her enthusiasm for science energizes those around her. Aletta, we are eager to hear from you today. After Aletta's presentation, we'll open up some time for questions from those in the room and online. Those online can use the chat or raise your hand and we'll call on you. But now, without further ado, Aletta, we welcome you to the podium.
Thank you, everyone. I would like to start by thanking our former Dean, Dean McKenzie, for the invitation. And I wish her very well on her upcoming adventures. I would also like to once again congratulate Dean Pollack Porter for being our new dean. I look forward to doing more work with you. Thank you, everybody, for coming. And for those who are online, I really appreciate you taking the time. I also would like to point out that I have some of my family from South Africa who are joining us online. My mom is struggling with connections, but I think she's on the phone and she's listening right now. So when I was thinking about what to talk about, I struggled a little bit. I thought it would be interesting, though, to connect the dots between my training, some of the experience I had during my training, as well as the work that I'm doing here. I have worked on very many, many collaborations. Some of them I may not be able to mention during this talk, but please do not feel offended if I don't say anything about the work that we've done together. I also do promise you that I won't be showing you any equations. There may be a couple of tables with numbers in them, but that's about it. And so I've mentioned the disclaimer that I will not be able to talk about all the projects that I've been involved in. So I was thinking about like what really inspires me to do work. When I was a student, I remember realizing the importance of having good data, evaluating healthcare data and making sure that it's of good quality to allow us to answer some serious, important public health questions. Of course, over the years, I've had a whole lot of questions around public health, and I think I share those with you, these concerns about why are people not accessing healthcare? How can we make it easy for them to access healthcare? And questions around some people who experience more poor health outcomes than others. What can we do about that? And also what really causes it that some people have many poor health outcomes much more than others? How can we encourage people to seek care early when they have disease symptoms? And how can we improve timely diagnosis of illnesses? I would like to actually start by acknowledging the fact that as public health researchers, we often talk a lot about numbers and population level scenarios, but really there are people behind these numbers who experience the diseases that we're talking about, and it's really personal for them and very challenging for them. So I just want you to acknowledge that, because throughout my talk it may seem like all I'm fascinated by is numbers, but I just want to say that I recognize that there truly are people behind these numbers. So why do this work? I visited a relative up in Michigan together with my family about 4 weeks ago. And this magazine happened to be in their guest bedroom. And I don't know if it was just a coincidence or if I really needed a reminder as to why I have to keep doing the work that we're all doing. And this was just talking about the world's deadliest infectious disease, which is TB. And so of all the infectious diseases that we've identified, TB is the leading cause of death among them. And if you don't believe me, for those, my nieces and nephews online, you can go to Google and you'll actually see that what's going on there. And so in the same vein about why do this work, there's still a lot that we need to do in HIV. Domestically in the United States, we still have high numbers of infections diagnosed every day, as well as in other countries and my home country of South Africa. On the right-hand side, there's a picture of Prof. Kangelani Zuma, who I've had the pleasure to meet. The lady on the left, I've never met, but she was the CEO at the time. I think this was released, a CEO of the South African National AIDS Council. And I like that picture because she has my mother's maiden name. So I thought, my relatives doing great things. But this is just a reminder that we still have too many new infections every year. So the epidemic is really not over. Of course, we've had some progress. There is now a single daily pill for ART for people living with HIV. There's the 2-monthly and 6-monthly injectable preventive therapy that we all have heard about more recently. It did take me a long time, but eventually I got here. I would talk about my grade school, of course, but then we would be here all night. So I decided to just start talking about my experiences from the University of KwaZulu-Natal, moving on to the University of Edinburgh in Scotland, where I did my research at the Biomathematics and Statistics Scotland, and the University of Birmingham, UMass for my postdoc, the London School, and then ultimately I made it here. I have 4 themes that I would like to talk about today. First, of course, I'll address the elephant in the room, what clearance of food from the sheep's stomachs got anything to do with this, and what apple tasting has got to do with it. And then I'll talk a little bit about high-dimensional data as well as my current and future work. So repeated measures, you may wonder, what are they? I know some of us in the room do know what those are, and those online. But imagine this very weird but interesting question that I worked on with Prof. Linda Haynes, who was my advisor at the University of KwaZulu-Natal, and Prof. Jonathan, who continues to mentor me, but is now actually retired adverts, but still does work there. So the question about, does the type of diet increase degradability and clearance of food from the rumen for increased roughage? So that's a picture on the left-hand side there of the stomach of a sheep. So the food gets placed in there, and over time, it's digested. So if you think about the data that come from there on that table, which is like one of only a couple of tables that I'll show you, you've got a scenario where you have experiments conducted over 3 different periods, and 2 diets are being evaluated here, one with and the other without the fish meal supplement. And then you've got 4 sheep. And in each of these sheep, they put food in the nylon bags and insert them in the stomach. And over time, on going down there 3, 8, 12, 12B, and so on, at the different time points, when they measure the proportion or percentage of the food that has cleared from the stomach. So this, if you took that data, of course, plotted it there, you see on the y-axis is the percentage of dry matter that has degraded, and on the on the y-axis, and on the x-axis you've got the time. And so what really are the analytical challenges? There are many. First, you've got this nonlinear relationship that we're interested in characterizing, and you've got the periods, you've got the repeated measures, so each sheep is measured multiple times under different conditions. And as many of you would have be familiar with this, there's a lot of variability within an individual sheep, and there's also variability between sheep. So that makes the analysis a little bit more complicated. And Prof. Haynes and I looked at the Bayesian, what we call Bayesian methods in statistics versus the frequentist approach to estimate and characterize this relationship between time and percentage. So moving from KwaZulu-Natal landed me here at Hopkins with this understanding of repeated measures data. The first few projects that I worked on were with Dr. Abdullah Baki, who's in the room. Thank you for coming. And here we were looking, the question, I remember actually sitting in his office and him asking me, Aletta, we're wondering, why is it that some women have so many adverse outcomes than others? So going back to if you remember the slide where I mentioned the different concerns that are always troubling me about public health, is why do some people experience more poor health outcomes than others? So Prof. Baki and others worked on this question of clustering of neonatal deaths among women. So how is this related to the sheep data? So if you look at a typical data set that would look like, if you look at this table here, you have different mothers and pregnancies. So each mother can have 1, 2, 3 or more pregnancies, and each of those pregnancies result in an outcome, which could be an adverse outcome, or it could be a good outcome, a live birth, or it could be a bad one where a child probably dies before they reach the age of 1 month, and stillbirth and all of that. So this is typically what the data look like, and therefore we have repeated measures within each mother. And so we would have between and within mother variation. So our conclusion there, after looking at the data and doing some analysis, and found that there's correlation between siblings outcomes. So if one pregnancy results in an adverse outcome, there is a high risk that subsequent pregnancies would also result in those outcomes. And so what happens at the mother level and the child level explained most of the proportion of the between mother variation. And we conclude that there may be some genetic factors that have to do with that. And looking at a similar type of data with Prof. Baki and others, once again, we looked at pregnancy intervals and whether they are associated with high risk of adverse outcomes in the same data in Bangladesh. And the conclusion there being that short as well as very long inter-outcome intervals are associated with a high risk of a similar outcomes in a subsequent pregnancy. So just another quick example on HIV outcomes that are repeated measures with Prof. Lauridine. We looked at economic burdens among men who are both men who are living with HIV and those living without HIV in the MAX cohort. I think some of us here have worked on this data set. It's a longitudinal data set where men come in and get evaluated twice a year. So you've got repeated measures and also repeated measures over time. And here, as you can see on the right-hand side there, the top left plot is showing in green that men living with HIV remained mostly, for all the years they reported being unemployed. They were likely to report income less than 10,000 a year, and but of course they mostly had health insurance. So then, basically, as we would all agree, the conclusion from this, we need to improve economic stability for people living with HIV in order for them to have better healthcare access and better outcomes. I know that as you would have guessed, I would not have completed this talk without talking about my mentor, Larry Moulton, who I appreciate very much. He introduced me to the world of cluster randomized trials. And some of you may be wondering what these are. And sometimes they're referred to as group randomized trials. And what are they? Why are they more complicated to design and implement as well as analyze? Well, if you do want to find out, you can join me in the fourth term, on Tuesdays at 3:30 p.m. I do meet with students who are interested in this, and we go deeper into the details as to what they are, how to actually design them and analyze them. But I'll just give you a little bit of an illustration of what they are. So in the cluster randomized trial, this is a simple example of a study where you're interested in evaluating, say, a vaccine, whether it's efficacious or not, or whether it's effective or not. So you assign groups of individuals. In this case, maybe it could be districts or some other geographic clustering, those who get the vaccine and those who do not get the vaccine. So it is a case of repeated measures, right? Because you've got the groups, and then within the groups, you've got multiple measurements. And even within the individuals themselves, they could be measured multiple times. Or at a group level, you could also have measurements taken at multiple time points. So it can get very complicated. So the statistical methods for analyzing those are not just straightforward. And what I find with cluster randomized trials is that they allow us to answer these questions that I've had. Remember that previous slide about the concerns I have? they allow us to answer these questions at a population level, right? For example, preventing disease, how do you reduce transmissions? And I've had the pleasure to work with wonderful people. I decided not to show the pictures of those who are here because I thought they would be shy and they didn't want their pictures shown. But I have worked with wonderful colleagues. One of them is over there, Dr. David Dowdy, Colleen Handrahan, and others here at the school. These are my colleagues who I'm learning a lot from, who are in South Africa, Prof. Neil Martinson and Dr. Di Makatso and other team members in South Africa. And so with them, we did some studies and cluster randomized trials. Once again, the same theme: to prevent diseases, reduce transmission, early diagnosis of TB so that we reduce transmission. And one of the first study I did with the team was on what we call the Karitore trial, where we looked at the approach of trying to diagnose people who have TB but may not know about it. And the WHO recommends that when a person walks into the clinic, you ask them questions about their symptoms, and then if they have the classic TB symptoms, cough, night sweats, and all that, then you test them for TB. But then here what we said, instead of doing that, what if we find TB diagnosed patients, ask them for consent, and then they go to the contacts in the community and then with some cash incentives and bring them in and have them evaluated. And the rationale, of course, is that if you are a contact of a TB diagnosed individual, you are at high risk of developing the disease and as well as transmitting it. So the earlier we diagnose you and treat you, the better. So in this case, clusters are the clinics as well, or clinics in the catchment areas. And that's why it was a cluster randomized trial. We did find, though, that in this study, it did not increase the number of diagnoses and the number of people who initiated treatment. And as I mentioned, once again, why are people not seeking care earlier on when they have symptoms and trying sort of like to get to that using the same data from the Karitore trial? I did an analysis, a secondary analysis, to try and see, why do people differ in the time it takes for them to seek care, and found many things, including the fact that when children do have symptoms, it's more likely for them to have the care sought for them sooner than older people. And education was associated with how quickly people sought care, and being other lifestyle factors like being a current smoker. So really, it's important for us to think about combinations of strategies that would help, encourage people to seek care, and we should integrate those into routine care so that they could be diagnosed earlier and to reduce transmission. Once again, still continuing on the same theme of diagnosing TB early with Prof. Martinson and others, we did what we call a TOUCH study, looking at, once again, the WHO says people come in, you test them for TB if they have symptoms, and we're like, okay, what if we actually expanded that and said, not only those who present with symptoms, but people who belong to certain risk groups, like people living with HIV, people who had been diagnosed with TB or are contacts of TB diagnosed individuals. What if we actually offer them testing as well? And that's why we refer to it as universal TB testing. And oops, and too fast. And so this was another study that actually we did find that, of course, you diagnose more people, and the Department of Health in South Africa adopted that as national policy. So now when you're in South Africa, you're supposed to be tested for TB, whether you have symptoms or not, as long as you have, you belong to these risk groups. Now, pivoting to the second theme about apples, I actually missed an opportunity earlier today because as I was leaving, my husband was walking into the garage with groceries and he had 2 big bags of apples. And I just missed that opportunity to take a picture and show you guys how much I love apples. What is your favorite apple variety, by the way? Anyone? No, you don't want to share? Oh, I like red, delicious. Should have worn red. So at the University of Edinburgh in Byres, I really was lucky to have wonderful mentors the late Mr. Rob Kempton, and Dr. Chris Theobald, who's online. I'm very grateful. And with them, we looked at these data. So at the HANA Research Institute, which I found out it's now closed down because of funding issues, but they do a lot of agricultural experiments there. For those of you who've never been, Edinburgh is up there on the map. This is the map of the UK, and on the red dot there, you'll see where the HANA Research Institute used to be, right south of Scotland in Ayr. And so they had, as I mentioned, people come in and do food tasting for various purposes, research purposes. On this plot here, I'm just showing the scores that were given by these assessors who were tasting different apple varieties and giving their rankings on how sweet they are. So the ranking ranged from 0 to 100, and on the y-axis there, and on the x-axis is like the different experiments that they attended. And the different colors refer to the different assessors. And when I visited that day, it was the ladies who came in. I'm not sure if they had gentlemen coming in testing, but yeah, I just thought about that question. I don't know if I ever asked. But and then on the right-hand side, there is just the plots of the means from our modeling. And there's a lot of complexities with this apple testing data. First of all, is multiple varieties that were being tested. And it's a repeated measures problem. Of course, it's, you have the within and between assessor variability. And then another thing is that there is no gold standard. I mean, when you're talking about the human perception point of view, I'm sure in the lab you can go in and measure how much sugar content there is in an apple. But in this particular case, when you're talking about the human perception of sweetness, there's this underlying or latent sweetness effect that can only be realized by what the assessor tell you, like the ranking and use of the scale. And there's a missing data issue. You saw that in the plot. Some ladies did not attend some of the experiments. So the analytical approach that we followed, using Bayesian statistics, combining prior knowledge, the expert prior knowledge, and the data that we observed in front of us, we quantified the average assessor rankings, characterized this heterogeneous interaction between the assessor and the apple variety. And it's heterogeneous because not all assessors will give a high ranking to the same variety. So it's all over the place. And quantifying the relative biases and variability between assessors, because some assessors would use a very small part of the scale, others would use a very wide part of the scale, which makes the data very complicated. And of course, also the model allows us to predict future performances as well. Now, how does that relate to the data on HIV? You're probably wondering. So I had an opportunity to work on these data. These are data from South Africa, and they're used to guide HIV programs and HIV policies. And on the y-axis is just the number of people that start ART at every given month. So the clinic would report these, and they reported, it just so happened here we had data reported in two different database systems, and one is depicted in a solid line and the other one on a dashed line. So as I mentioned, it's the monthly number of people living with HIV who started ART in those clinics in South Africa. And so moving from the model that we use for apple tasting studies and using really the same model to characterize what we see in the HIV reporting data, there are similarities, right? Both repeated measures, right? And we have assessors in the apple scenario. And in the case of HIV, you've got the clinics that are reporting, and it's even more complicated because now you've got these two database systems that are keeping track of the data. And there is no gold standard in the sweetness study, as I mentioned. You could also say there is no gold standard in the clinics, in the sense that there's some underlying time effect as to whether the numbers are going up and down, but it's not realized unless you actually hear from the clinic. So it's only realized through the reporting by the clinics. There's this heterogeneity in the apple by assessor interaction. Once again, the clinics, you see the heterogeneity in the clinic by time interaction. Not all clinics move at the same time. They don't go up and go down at the same months. And in the case of HIV data, we've got this discrepancy that we observed in the two database systems. And once again, in both scenarios, we fit a model, we develop a model that allows us to predict some future performance. So in evaluating this, we use the model to quantify these longitudinal trends. And as you can see here, this is the summary of what the trends look like, combining all the data from all the clinics together. On the y-axis is the estimate of the month effect, and it's negative because over months there was little decreases of the number of people studying ART. And this is on the x-axis is the months. And you see a dip there in the June, July kind of time period, as well as a big one in December, month 12. And the explanation that I could find or thought of, and my team members agreed, is that in South Africa we have a longish school break in the winter around June, July, and care-seeking behaviors change around that time. And you obviously all are aware of care-seeking behaviors that change when there's big holidays like the Christmas period. And on just at the bottom there, I thought it would be interesting to show you the discrepancies. Though on the left-hand side, there's two clinics. The database, one database system in teal and the other one in a reddish color there. That on the left we see a lot of discrepancies for some of these clinics, and then on the right we see some similarities. So identifying those discrepancies and being able to assess what the sources of them are, and in order to make sure that the data are of great quality and can be used for decision making. I actually came across this blog the other day. Andrew Gellman is a Bayesian statistician and writes blogs and talking about the rise and fall of Bayesian statistics. And I felt like he was talking about my career because, they were talking about how Bayesian statistics has fallen. Well, there was a time, and around the time when I was doing my master's training and Prof. Haynes introduced me to Bayesian statistics, it was a big hype, a lot of people doing Bayesian statistics, but not because people didn't know about it before, just because computing power wasn't allowing people to apply Bayesian methods before. So in the late 90s, early 2000s, we saw a big rise, and you could call it a big hype. But really, it doesn't mean that Bayesian statistics is no longer as important and useful. It's just that now, we know it's there. We can just apply Bayesian methods, and also there's been a rise in machine learning methods, and they've taken some part of the pie. And Bayesian statistics, he argues that it's become much bigger as well, but it's just maybe smaller relative to the entire pie. Theme 3, sorry, with Dr. Andrea Folks, who was my postdoc advisor at the University of Massachusetts, and she's now at head of statistics at Mass General Hospital. I was introduced to the world of high dimensional data. You're probably wondering what those are. They're basically data sets where you've got multiple tens, hundreds, thousands of features that are measured on an individual. And actually, Dr. Andy Ruff and I worked on one such problem. And so it could be for example, genetic markers or other disease biomarkers or brain signals. And I'm just showing you an example of such here. I found this online. I just stumbled upon it. It's not my research project. But here, there's just chromosomal locations, like trying to understand the genetic relationship between cardiovascular risk factors and Alzheimer's disease. So you can imagine these measured on all the individuals in a study. So it leads to quite a lot of data. And the goal of the analysis is usually to find those features or subsets of those features that explain the differences in biological traits that we observe. So with Dr. Folks, we looked at the machine learning algorithms, so statistical algorithms to explain these traits to find identify those genetic polymorphisms that explain the traits that we observed. And then when I moved to the London school, I did a Bayesian implementation for one of those applications. So I then came to Hopkins, and once again, because I'm interested in making sure that we get early disease diagnosis and find efficient diagnostic tools, I was lucky to work with colleagues in the School of Medicine at the TB Center, and with Dr. Susan Dorman, who I think now is at the University of South Carolina, as well as the TB-CDRC, the consortium that is still evaluating TB diagnostic tests, and we're also particularly looking at pediatric TB diagnostics with the goal of seeing whether we could use antibody responses to distinguish between children who have TB and those who do not. As most of you may know, that it's very difficult to diagnose TB in children. So Dr. Susan Dorman and I looked at these serologic responses in children. On the left-hand side, there is a plot of what we call the AUC, the area under a curve. It is a measure of discriminating ability. And we have children who are confirmed to have TB and those who are unlikely TB patients. And so on the y-axis is that AUC. The higher the AUC, the better discriminating power. On the x-axis is the antigen. So we used cross-validated generalized linear models. We can talk about that later if you want to know what those are. And that allowed us to select those most predictive combinations of antigens that would help us do that. And as you see, if you combine all the children, the AUC is a little low. And also if you look at the younger children here in the middle plot there, shows very low values of AUC, but a little bit better when you go up. And the conclusion, of course, is that it's very unlikely that we could have an antigen-based test that would help us distinguish between TB and non-TB children. It's a little bit better for older children, but much harder for the younger children. As I mentioned, I didn't put pictures of people up there because I don't want them to get upset with me. But then I thought I'd pick on one person who is in the room. Thank you very much for coming. Prof. Richard Chasen is a medical doctor and is across the street in the School of Medicine, has a joint appointment here. And I just want to acknowledge and appreciate his guidance and appreciate his mentoring over the years and of course many other colleagues in the Department of Infectious Diseases and the TB Center in the School of Medicine. I really appreciate it. And so with them, we're doing a lot of work once again to prevent disease. You probably could say it with me now because I've said it so many times, right? Reducing barriers to accessing healthcare and promoting care seeking. So we're involved in many studies looking at answering questions such as how safe it is to combine TB preventive therapy with HIV antiretroviral therapies in children, pregnant mothers, and everybody else. Adherence and completion outcomes when people are on TB preventive therapies. Can we have shorter course regimens for TB prevention or TB treatment? And would they be just as efficacious as the existing ones or longer regimens? Large-scale TB testing and TB diagnostics, including like tongue swabs. I'm working with Neil Martinson and others on those, and decentralized testing. Actually, Emily Kendall and David Dowdy and others are looking at that in Uganda. And with HIV, with Cherie Schwartz, who's sitting over there, thank you for coming, looking at strategies for improving uptake of HIV preventive therapy. I mentioned earlier that we're lucky now we have these newly developed, long-acting injectables. How can we get people on them to prevent transmission, people acquiring HIV? Still on the preventing of disease, just a couple of examples of some recently published studies with the team across the street, Dr. Chasen and others. We recently showed that combining 3HP, which is a TB preventive therapy, and ART was safe if you initiate it simultaneously. safe and achieved therapeutic concentrations with also Nicole Salazar-Austin and others looking at whether going to households of TB diagnosed individuals and studying children who are exposed or at risk of developing TB disease and getting them on preventive therapy, and found that we could initiate more children on the therapy than the standard of care, which is asking TB diagnosed people to bring in their contacts. So instead of waiting at the clinic for them to come in, we actually go to their households. And one of the statistical design and analysis challenges that I'm facing, and Sherry can attest to this, is the issue of designing and implementing these pragmatic studies in this changing landscape. There's a lot of developments and changes, improvements in TB preventive therapies. We've improved, but we really struggle still to reach optimal levels. The incidence rates, as I've shown, are declining, but we're not at zero. So how do you design pragmatic studies and evaluating strategies to improve uptake when there are so many changes? I mean, the 6-monthly injectable for HIV prevention was, I think, was announced last year in July. And so there's a lot of changes in uptake and people's attitudes towards those. And just, just to illustrate what the challenges are with Kate Shearer and others, Chris Hoffman, Jonathan Golub, and others, we recently got this study published looking at uptake of TB preventive therapy in 3 different countries in Southern Africa. And as you can see, Mozambique, of course, doing very well. And when we did this in Malawi and Zimbabwe, there was a big push nationally to improve the uptake. And so we conducted the studies. There was, as you can imagine, a lot of confounding factors. Things are already happening, but then you're also trying to evaluate this strategy in the same setting. This was work done with our MPH student, Aletta, looking at the trajectories of TB diagnosis in South Africa. And this was before COVID. We all know that after COVID, things went a little bit crazy with TB diagnosis. But in South Africa, we the numbers were going down. And so this is just an illustration of the changing landscapes. I just want to take a moment to just acknowledge the fact that as we continue to do this work, the context within which we do our work, as we know, we always have to remind ourselves and always try to do better. Ask ourselves, are the domestic partnerships, both like in Baltimore and the US, as well as internationally, we all trying to save lives, a million at a time, which is our motto. Are those equitable, right? We know we have a history as well as social beliefs that are perpetuating inequities that we see in healthcare, coloniality, racism, and others. And really the question is, what are we doing about them? And another one which we're experiencing at the moment is how we finance our work. Well, actually, we've been experiencing it for decades. Maybe we haven't been talking about it as much. We've seen efforts by the global South countries to try and reduce this heavy reliance on the global North for funding to do public health research. And I believe that we should be allies because there are historical events that led us to where we are today. And so we need to work together so that we can change the way we do things and do, gain more improvements in public health. And on the question of what are we doing about it, I do believe that we need to embrace the inclusivity, diversity, anti-racism, and equity principles. If you want to know more about that, term 3, Dr. Emma Sachs and I have a seminar series in which we go into some details and invite speakers to come and talk to us about these issues. And I've had the honor to co-author, led by Ms. Megan Harrison, a colleague of ours here, on the use and creation of photographic imagery in global health. Are we still perpetuating colonial mentality in how we use our pictures in our work. I just want to quickly mention also, I really appreciate working with trainees and students and postdocs. One of the postdocs funded by CIFA at the moment, Dr. Ekwa, and all the PhD students, and the funding, really appreciating funding from the NIH and federal government and other funders as well. And I would also like to quickly say a quick thank you to all my colleagues in IH, and just those two people on the picture there. They are women who I admire a lot in their guidance over the years and their mentoring. Joanne and Andrea, I really appreciate you. I would like to thank the apples and the sheep. I wouldn't be here without them. But on a more serious note, the patients slash participants of the Bangladesh neonatal outcome studies and the TB and HIV studies, as I mentioned at the beginning, sometimes it seems like we're just talking numbers at a population level, but really there are people behind these. There are people who are struggling with these diseases every day. I just want to thank them for allowing us to use the data to help guide policies. A lot of funders, a lot of colleagues at the Biostatistics Center here in the Department of Biostatistics, through whom I've made a lot of connections and formed these collaborations. The Department of Health in South Africa, the Department of Health in Uganda, Peru, Malawi, all these other countries we've worked in, I really, really appreciate the PHRU colleagues and people that I've mentioned across the street in the School of Medicine. My grandparents. I did mention earlier on that the person on the picture I had never met has my mother's last name. So I thought I'd just put that picture there to show you that I wasn't making it up. That's my mother's last name. But that's my grandfather and with my two cousins. My grandfather on the right-hand side, my grandfather and my grandmother, whose lessons I really value. I'm really grateful for their love and the values that they've instilled in us, and I wouldn't be here without them. My siblings, this picture was taken when my mom was really, really young, about 20 years ago. Those are my three siblings. And now she's a 90-year-old who likes to take selfies, and she's listening in if she hasn't fallen asleep yet. And that's that. The three people right here, Barry Magnus, my husband, I really appreciate your support. Thank you very much. Monewar, my son, and Kumo, my daughter. And I just want to note that Monewar made some big sacrifices today because today was supposed to be his first soccer game at a new school, and he decided to come and be here with me and miss the game. Thank you very much. Thank you, everybody.
Aletta, thank you so much for that wonderful talk, and thank you for sharing some of yourself with us today. We have some time for questions. We have mics in the room so people on Zoom can hear. And we also invite people on Zoom to also post your question in the chat or raise your hand. So let me see if there's anyone who wants to ask a question or make a comment to Aletta. Okay, we have I'll head to the back, Becky. Oh, I got it, yeah. Get my steps in.
Thank you so much. Hi, I just want to say, first of all, thank you for the wonderful lecture. My name is Jeff. I am a current graduate student here at the Bloomberg School of Public Health. And my question for you is, you have mentioned in the later portion of the lecture about conveying the data as well as the research finding to actual public health policy works. I am wondering, what are some of the most effective way for you to translate research finding from data and statistic into actual practicable knowledge and policy and initiatives?
Yeah. Thank you for that question. I do find that having a relationship with relationships with the stakeholders. And in the case that I mentioned before, Prof. Martinson and others in South Africa really work very closely with the Department of Health and really trying to understand what the where the gaps are, understand what the needs are in order to help the department sort of, get the answers to the questions that are of most important to the public. So I think I would say that's one way you want to do it. You don't want to just be the scientist who does wonderful research without actually asking the people, what do you need? What is needed? Where should we be looking in order to find answers to our public health questions? So those relationships are very important. And also they give you money. If you're nice to them, they'll give you money to do your research.
David Sack. I wanted to ask, as a statistician, you obviously have been working with so many different investigators. How can you keep all your investigators happy, and how do you keep track of all the different studies that you have to be involved with?
I've never asked them if they're happy or not. Maybe I should ask them. It is a challenge. But I work with lovely people. They understand if I'm busy writing a paper at some point, and they send me an email. They're like, okay, can you look at this? I'm like, can you give me 2 days or 2 weeks or 2 months? But I must say, over time, you sort of try different skills to juggle. But the most important thing is to ask for help. I used to be shy to say, no, I am not able to do this right now, or I'm not able to do this, within a certain period of time. And I have been lucky at some point to get assistance from other analysts, or within the team ask data managers to help me, say, for example, to assemble a data set so that I can come in and look at a data set that's already assembled. Of course, we work together as to the algorithms that we follow to assemble that working data set. So yes, it sometimes, yes, it is overwhelming. But the thing is, I like shiny balls. I'm always interested in the new thing. So if you come to me and said, I have this project, I'm like, yeah, let's go. What can we, learn from it? So I do like to work on different studies. So it's some, like, I thrive on that. But I do also have to acknowledge that I can't do everything myself. I have to ask for help. I have to ask the data managers that I work with, or if we could hire an analyst to be on board. And I think Dick knows about that. I'm always screaming about, can we get an additional analyst for the team? That's really how we can get it done.
Hi, my name is Fanny. I'm an MHS student in mental health. And first of all, thank you so much for the presentation. And my question was revolving around, so since you're a statistician, you're working with numbers, what strategies do you take to humanize them, not only to the politicians who would be enacting the policy, but also to just the general public? And also, how often and how valid is it to take this data, say that you obtained from Bangladeshi individuals, and then translate it to a completely different culture? Has that happened, and how would you, support that transition to a different culture?
Right. Yeah, you're right. It can be challenging, right? We always have to remember that we're not just looking at numbers. We're looking at individuals who are living with the diseases, right? Who are facing the risks. And I think when you approach it, I think to answer your first question, approach it with a lot of empathy. And as a statistician, sometimes people don't understand when I ask some of the contextual questions and say, can you just tell me exactly what happens when a person walks into the clinic? In order for me to try and help with the design of the study and how we're going to collect data and all that, I need to understand all of that. So really just understanding and really have empathy as well of what goes on in real life, because sometimes we statisticians just want perfect data that look a certain way, but we need to actually acknowledge the fact that things are not as pretty, things are not as straightforward when you they're a bit messy, how things happen in real life in healthcare settings and all that. But in terms of how I translate lessons learned from some settings to others, that's actually a very good question. You do have to be careful with that. We do run a risk, and you see that in different institutions, and not just in institutions like research institutions than ours, but you find that people make assumptions that what I see in Baltimore, I'm going to see in Chicago as well. And this is where it is important to talk to the stakeholders, talk to the people on the ground, community bodies, and talk to them about really, if we say that we have these findings from this place and we assume those findings would apply there, is it really realistic? How does the health system here work relative to the other? And so it's very important, and it's also very important to conduct these studies in different settings in order to capture that heterogeneity, because places, as you say, are not homogeneous. So I think going through those processes, I mean, working with all my colleagues in here, all of them, we work in so many different countries, and the design aspects are not straightforward. I'll just give you an example of the trials that we're working on. When we do randomization, I generate randomization schedules. And so I ask them, okay, tell me, what does it look like in Peru? What kind of participants are we likely to find? What is the HIV prevalence among the participants there? What does it look like in India? And it is challenging. I mean, I wish I could just generate a randomization schedule that's like, okay, here you go, everybody gets this or that. But no, I actually generate what we call a stratified randomization schedule, stratified by the different sites where we're working. That's just one quick example of that.
Thank you.
Great. Thank you so much for the questions. I know that we're a little bit past time. I will hold my own question and encourage people to follow up with you, including myself. I have questions for you. And I just want to take a moment and just ask you all to join me in just thanking Aletta for such an amazing talk. Thank you for sharing your work and your story and your journey. And thank you for the wise words. And one thing I'm taking away from this talk is this emphasis on mentorship and on listening to community, and also the importance of being with community, and that there are people behind the numbers. And so I hope that those were some lessons you wanted to impart. That's what I received, some of the things I received from your talk. So thank you so much. And thank you all for being here.
Thank you.